My name is Katy Kozhimannil. I'm a professor at the University of Minnesota School of Public Health, and I'm grateful for the chance to share with you about research we recently published in the American Journal of Public Health. We conducted an analysis of data collected from people who gave birth in the United States between 2016 and 2019, and we measured rates and predictors of intimate partner violence and abuse screening in this population. This is an important topic, and it can also be difficult for survivors and others affected by violence. Please take care while listening, and thank you for taking the time to learn about our work. I'll start with some background information and then tell you about the research we conducted and what we found, as well as what our findings mean for the health and well-being of people who give birth in the United States. Most folks are aware that maternal morbidity and mortality are rising in the United States, with some of the highest rates occurring among Black people, American Indian Alaska Native people, low-income individuals, and rural residents. What a lot of people don't know is that intimate partner violence is a leading non-obstetric cause of maternal morbidity and mortality. Intimate partner violence includes physical, emotional, and sexual violence and comprises patterns of behavior to gain or maintain power and control. While physical violence is a commonly recognized form of IPV, emotional and sexual violence are also harmful and prevalent, and I want to take a moment to talk a little bit about that. Specifically, examples of emotional violence include verbal insults, humiliation, isolation from friends and family, threats of harm, control of finances, and monitoring of communication and location. Sexual violence can include forcing or attempting to force a partner to take part in a sex act, sexual touching, or a non-physical sexual event like sexting when the partner does not or cannot consent. Maternal experiences of intimate partner violence are associated with poor birth outcomes, including higher rates of preterm birth, lower birth rates, and lower rates of breastfeeding. Risk for the most severe outcome, homicide perpetrated by an intimate partner, is heightened around the time of pregnancy and childbirth. Approximately 60% of homicides that occur around the time of pregnancy are related to intimate partner violence. Universal screening for intimate partner violence and abuse is recommended by multiple professional organizations. Since 2012, the American College of Obstetricians and Gynecologists has recommended regular IPV screening during pregnancy and the postpartum at all healthcare visits. And in 2018, the U.S. Preventive Services Task Force upgraded their recommendation, supporting universal screening nationally. Understanding the extent to which birthing people experience IPV and whether they receive screening at healthcare visits before, during, and after pregnancy can inform public health services and policy. The goal of this study was to measure IPV screening during the perinatal period among those who were experiencing physical violence in a large sample of U.S. residents who gave birth, and to discuss strategies to reduce the inequities that we identified. We used 2016 to 2019 data from PRAMS, which is a survey of U.S. residents who recently gave birth. The sample is representative of over 80% of births in the U.S. and includes data from 42 states and 2 U.S. jurisdictions, but there are several states that are not included. This analysis focused on 2 outcomes: whether respondents reported experiences of physical violence by a current or former intimate partner, and whether respondents were not screened or lacked screening for physical or emotional abuse at healthcare visits. Though IPV includes physical, emotional, and sexual violence, as I mentioned, the measures available in PRAMS only assess experiences of physical violence and screening for physical or emotional abuse. To measure experiences of IPV, we used a PRAMS survey question about physical violence. The question asked whether the respondent had been pushed, hit, slapped, kicked, choked, or physically hurt by a husband or partner or an ex-husband or partner. This question was asked about the preconception period, the 12 months prior to pregnancy, and during pregnancy. To measure non-screening for abuse or lacking abuse screening, we used a PRAM survey question about healthcare visit attendance and abuse screening at healthcare visits. Respondents were asked whether they had any healthcare visits during the preconception period, the 12 months before pregnancy, prenatal care visits during pregnancy, or a postpartum checkup visit between childbirth and the time of the survey. If respondents reported having visits during these time periods, they were then asked a series of questions about screenings at those visits. Specifically, they were asked whether a healthcare worker asked at that visit if someone was hurting them physically or emotionally. We focused on lack of abuse screening in this analysis among those experiencing intimate partner violence, given the importance of identifying people who are experiencing violence and are not receiving appropriate preventive or supportive care. This analysis included data on 158,338 postpartum individuals that were interviewed between 2 and 6 months after childbirth. We used logistic regression models to estimate respondents' predicted odds of experiencing physical intimate partner violence. Among those who reported physical IPV, we also estimated respondents' predicted odds of not being screened for abuse. These analyses allow us to understand who is most likely to experience physical violence from an intimate partner, as well as who is likely to not be screened for abuse by a healthcare provider. In this analysis, we found that physical violence by an intimate partner was reported by 3.5% of the sample. Accounting for survey weighting, this equates to approximately 280,000 people who gave birth in the US between 2016 and 2019 in 42 states and 2 US jurisdictions who reported being pushed, hit, slapped, kicked, choked, or otherwise physically hurt by their intimate partners. That's more than 250,000 people who are experiencing physical abuse around the time of pregnancy. Consistent with prior research, we detected higher odds of experiencing IPV among rural residents, among non-Hispanic Black people, American Indian and Alaska Native people, younger birthing people, those with unintended pregnancies, and folks with clinical complications. We took a closer look at IPV victims to better understand patterns of screening for abuse at healthcare visits around the time of childbirth. Among those experiencing violence, 58% were not screened before pregnancy. Almost 27% were never screened during prenatal care visits, and almost half were not screened in the postpartum period. Among birthing people reporting physical violence by an intimate partner, nearly half were not screened either before or after pregnancy. These individuals reflect a critically at-risk population for whom targeted clinical and policy interventions may be important and impactful. There are 2 reasons that IPV victims might not have been screened. Either they did not have a healthcare visit, or they were not asked about abuse at the visits they attended. And we found that these were two very different groups of people. First, we had victims who did not attend healthcare visits. So nearly all of the people in this sample had at least one prenatal care visit. So the folks who were IPV victims who were not screened during pregnancy, many of them were not screened because they were not asked about visits. But there were large portions of the sample that did not have a visit prior to pregnancy or in the postpartum period. Notably, these folks had characteristics that were associated with more limited access to care. For example, those reporting Medicaid or uninsurance, no insurance at the time of childbirth, American Indian, Alaska Native people, and Spanish-speaking Hispanic people faced increased risk of not having a healthcare visit during which screening might occur. Again, these folks are all IPV victims. On the other hand, among IPV victims who attended healthcare visits, including almost everyone who attended a prenatal care visit, there was a different group of people that were more likely to face an increased risk of not being screened for abuse at the visits they attended. And this included privately insured people and non-Hispanic white respondents, as well as rural residents. These findings have important implications for clinical and policy efforts to address maternal health. Many recent policy efforts addressing maternal health and maternal mortality have focused on clinical risk factors, including and especially the quality of hospital-based care. That's such important work. And additionally, maternal safety outside of the clinical setting, including in homes and communities, is important. Potential policy efforts to improve the health and safety of IPV victims and to prevent future intimate partner violence may include investment in home and community health for birthing people, addressing gender inequities and the normalization of violence within intimate relationships, educating and training providers and staff who interact with pregnant and birthing people about IPV, its manifestations, and its effects on health and well-being. This study found that approximately half of birthing people who reported physical violence before or during pregnancy were not screened because they did not have a healthcare visit in the year prior to pregnancy or postpartum, or because they were not screened at the visits they attended. These findings imply a critical need for increased healthcare access and better screening to identify and support people experiencing violence by an intimate partner. More broadly, clinical and policy efforts to improve maternal health in the US should address IPV as a health policy issue. I'd like to conclude first by acknowledging my presence on the traditional, ancestral, and contemporary lands of the Dakota and Anishinaabe people. I encourage everyone to consider that Indigenous people, especially Indigenous women, experience disproportionately high rates of violence, including intimate partner violence and maternal mortality. On behalf of the author team, I'd like to acknowledge the financial support we had for this research. And we also gratefully acknowledge the pregnancy risk surveillance and monitoring system, the PRAMS study participants, and members of the PRAMS working group at the CDC. Finally, I also want to acknowledge the incredible team of experts that collaborated as authors on this analysis. This is our first collaborative project, and we come together as experts who are also personally impacted by the topic of intimate partner violence. I want to elevate the value of conducting health services and health policy research that is grounded in the lived experience and includes the voices of those most deeply impacted. Thank you so much for your time and attention. I really appreciate your learning about our research today. Thank you.